Hello students, today's class is on thalassemias. Thalassemia is an inherited impairment of hemoglobin production. As you know, there are alpha and beta chains for the hemoglobin, and so depending on which chain is affected, there is either the alpha thalassemia or beta thalassemia. There is a partial or complete failure to synthesize a specific type of globin chain. So, types of thalassemias, there is alpha thalassemia and beta thalassemia. Alpha thalassemia is due to disruption of one or both alleles on chromosome 16. So, there is either production of some or no alpha globin chains. In beta thalassemia, there is defective production usually results from disabling point mutations causing no or reduced beta chain production. The inheritance of thalassemia is autosomal recessive. So, if both the father and mother are carriers for the thalassemia, 25% of the children can have thalassemia, 50% are carriers and 25% are healthy. First, we will discuss beta thalassemia, which is a more commoner form of thalassemia. Beta thalassemia occurs due to failure to synthesize beta chains, and this is the most common type of thalassemia. So, the heterozygotes have thalassemia minor and homozygotes have thalassemia major. So, heterozygotes is a condition in which there is usually mild microcytic anemia and little or no clinical disability. But thalassemia major, either they are unable to synthesize hemoglobin A or produce very little hemoglobin A, thus producing the manifestations of thalassemia. So, beta thalassemia occurs due to genetic defects in chromosome 11, and with one mutation there is less production of hemoglobin and there is a beta thalassemia carrier and there is only slight anemia in such conditions. But with two mutations there is no beta globin production and therefore beta thalassemia major occurs with patient having severe anemia. So, depending on the type of mutation, it can be beta thalassemia trait, beta thalassemia intermedia or beta thalassemia major. So, when it is homozygous, it is beta thalassemia major called Cooley's anemia. Beta thalassemia major has severe anemia, there is transfusion dependence. Because there is anemia, these children will have to be transfused at regular intervals to maintain a normal hemoglobin level. And because there is hemolysis, there is an extramedullary hematopoiesis resulting in hepatosplenomegaly, and due to recurrent transfusions there is a risk of iron overload. Beta thalassemia intermedia can have variable severity depending on the amount of beta chain that is produced. They can have mild to moderate anemia with a possible extramedullary hematopoiesis, and depending on the amount of transfusion that is required, they can have iron overload. Beta thalassemia trait is thalassemia minor. It may be asymptomatic or it can produce mild microcytic hypochromic anemia. So, the clinical features of thalassemia major in children with no transfusion or inadequate transfusion, if there is severe anemia, it can lead to a natural course of the disease and the child may die within 5 years of age. But in children in whom there is regular blood transfusion, the manifestations of iron overload can occur at the end of first decade. So, there is anemia requiring transfusions, and recurrent transfusions can lead to iron overload. So, in children in whom there is regular blood transfusion but no iron chelation done, the manifestations of iron overload can happen at the end of first decade. But in children with regular blood transfusion and chelation, they may enter into normal puberty and have a normal life expectancy. So, general features are pallor, fatigue, dyspnea on exertion, poor appetite, palpitations, poor growth. So, these are features of anemia, basically features of anemia. And because there is extramedullary hematopoiesis, there will be features of marrow expansion. As you can see in the figure, the child can have excessive erythropoiesis leading to facial changes. There will be maxillary overgrowth, malocclusion of teeth, frontal bossing, They can have recurrent infection in the form of chronic sinusitis, impaired hearing, etc. Now, extramedullary hematopoiesis can result in hepatosplenomegaly. They can have scoliosis, kyphosis, vertebral collapse with cord compression. And it is in the group of hemolytic anemia. So, features of hemolysis like jaundice, hyperuricemia leading to gout, gallstones can also occur in such children. So, as I said, when these children have anemia, they have to be transfused with blood, and recurrent transfusions can lead to features of iron overload. They can have dark skin, deposition of iron in the liver can lead to cirrhosis. It can deposit in the heart to produce arrhythmias or heart failure. They can have deposited in the endocrine organs producing diabetes, infertility, pituitary failure and hypothyroidism. The features of iron overload are hyperpigmentation, cirrhosis when it affects the liver. It can affect the heart resulting in arrhythmias, cardiac failure. It can produce endocrine problems like diabetes, infertility, pituitary failure and hypothyroidism. So, iron overload can result in endocrine failure. As you can see here, this is an 18-year-old male with beta thalassemia major who has had recurrent transfusions, and as a result he has developed iron overload. So, there will be short stature, delayed puberty, there will be estrogen and testosterone deficiency, they can develop diabetes mellitus, hypoparathyroidism, etc. So, signs and symptoms of thalassemia. Beta thalassemia major is either asymptomatic or only mild symptoms with mild persistent anemia which will not respond to hematinics. Beta thalassemia major manifests after 6 months of age with pallor, failure to thrive, fatigue, irritability, growth retardation, recurrent infections, bony abnormalities as we had mentioned with facial bones, hemolytic facies, enlarged liver and spleen due to extramedullary hematopoiesis. They will have delayed sexual development, features of complications. So, diagnostic features of beta thalassemia. Beta thalassemia major, that is a homozygotes, will have profound hypochromic anemia requiring transfusion. There will be evidence of severe red cell dysplasia. There will be absence or gross reduction of the amount of hemoglobin A when you do the hemoglobin electrophoresis. There will be raised levels of hemoglobin F and evidence that both parents have beta thalassemia minor, because then only the child can have a homozygous genetic makeup. And beta thalassemia minor, its heterozygotes will have mild anemia, microcytic hypochromic anemia, some target cells and punctate basophilia may be seen, but there will be raised hemoglobin A2 fraction and they are asymptomatic or mildly symptomatic. The X-ray skull of a thalassemia major has a characteristic hair on end appearance. So, what you see here is the hair on end appearance that is characteristic of beta thalassemia. There will be widened diploic spaces because of the extramedullary hematopoiesis and thinning of cortex. The X-ray of the hand will show rectangular appearance. You can see the metatarsals are rectangular in shape. The medullary portion of the bone is widened. The bony cortex is thinned out and the coarse trabecular pattern in the medulla. So, these are characteristic features seen in thalassemia: the hair on end appearance in X-ray skull lateral view and the rectangular appearance of the metacarpals. Now, coming to treatment of beta thalassemia major. So, the major manifestation is anemia which requires blood transfusion, and so for the erythropoietic failure you can do a allogenic stem cell transplantation, hematopoietic stem cell transplantation from an HLA compatible sibling. There will be transfusions to maintain a hemoglobin of more than 10 gram per deciliter, and folic acid supplementation 5 milligram daily is done for the erythropoietic failure. So, because of recurrent transfusion the child can have iron overload, so you have to give iron chelation therapy, and iron therapy for anemia in beta thalassemia major is contraindicated because we can develop iron overload. So, even though beta thalassemia major has a microcytic hypochromic appearance in peripheral smear, iron therapy is contraindicated. And if there is massive splenomegaly causing mechanical obstruction, and massive splenomegaly with hypersplenism leading to excessive transfusion needs, you may go forward with splenectomy. So the management is basically transfusion, prevention of iron overload by iron chelation, and methods to increase the fetal hemoglobin induction by drugs like hydroxyurea can be used in beta thalassemia major, and splenectomy when there is hypersplenism or mechanical obstruction due to the massive splenomegaly. The prognosis of beta thalassemia major, the life expectancy without regular transfusion is less than 10 years. With regular transfusion and no or poor iron chelation, it is less than 25 years. But with regular transfusion and good iron chelation with desferrioxamine, etc., 40 years or longer. So it has a good life expectancy if the adequate transfusion and prevention of iron overload with chelation, iron chelation is done. And the most common cause for death is iron overload in beta thalassemia major. Now coming to alpha thalassemia. Alpha thalassemia occurs due to the mutation in chromosome 16. There are 2 alpha gene loci on chromosome 16, and therefore each individual carries 4 alpha gene alleles. So if one is deleted, there is no clinical effect. If 2 are deleted, the child can have a mild hypochromic anemia. If 3 are deleted, the patient has a hemoglobin H disease, and if 4 are deleted, the baby is stillborn with hydrops fetalis. So chromosome 16 defect results 1 gene deletion, it is a silent carrier, 2 gene deletion produces thalassemia minor, 3 alpha gene deletions produces hemoglobin H disease, and 4 alpha gene deletions can result in hydrops fetalis, or what you call as the erythroblastosis fetalis. So trait and silent carriers are asymptomatic HbH, hemoglobin H disease, moderate to severe hemolytic anemia, modest degree of ineffective erythropoiesis, splenomegaly, and variable bone changes can occur in hemoglobin H disease, and HP BARTS the baby will be born with massive generalized edema called hydrops fetalis, and it is usually fatal. So in alpha thalassemia silent and alpha thalassemia minor, the hemoglobin A is the major form of hemoglobin. In HbH, the Bart's hemoglobin is less than 10%, but 5 to 40% is hemoglobin H, and in hydrops fetalis 70 to 80% is hemoglobin Bart's. Hemoglobin H is a beta chain tetramer formed from excess of beta chains, which is functionally useless, so that patients rely on their lower levels of hemoglobin A for oxygen transport. So treatment of hemoglobin H disease is similar to that of beta thalassemia of intermediate severity with regular transfusions, folic acid 5 mg per day supplementation, and transfusion if required, and avoidance of iron therapy. 8th of May is the International Thalassemia Day. This day is dedicated to thalassemia to raise public awareness for prevention of thalassemia and to highlight the importance of clinical care for thalassemia patients in all countries. That is 8th May every year. That is the International Thalassemia Day. That's about thalassemia. Thank you.